Hi, everyone, and welcome to a panel discussion on law enforcement presence and divestment in hospital settings. My name is Bijou Basu, and I'm currently the chair of Doctors for America's Health Justice and Equity Impact Area, and I'm currently an MD PhD student at Case Western Reserve University. Before we get started, I wanted to take a quick minute to invite you to officially join Doctors for America. Being a DFA member today means taking the important and simple step of selecting a membership level and paying your annual membership dues to support DFA's organizational sustainability. There are 6 different levels to choose from, and a DFA team member will put the link in the chat. We will also be live streaming to Facebook Live and making a recording, and all materials will be available afterwards. A few ground rules for this educational session. First off, there is no such thing as a stupid question. And speaking of questions, please remember to use the Q&A feature. We will address your questions during the second half of our session. And also look out for comments in the chat. A DFA staff member will be sharing helpful links during the session. So the next thing I'd like to do is introduce all of our amazing panelists. So first up, Bakura Shabazz. She has over 2 decades of grassroots and professional advocacy experience in many issue areas, with criminal, environmental justice, and child welfare reform as her areas of expertise. She currently holds the position of Community Engagement Liaison with the Virginia Environmental Justice Collaborative and serves as the Chesterfield and Richmond, Virginia Mini Democracy Center lead. Ms. Shabazz's advocacy spans nationwide, as her ability to read and apply law is one of her gifts from God and her calling. Ms. Shabazz is the founder and president of First Alliance Consulting LLC, the Criminal Injustice Reform Network, Mothers Against Mandatory Minimums, and the Coalition for Families Against Child Separation, and One City, One Voice. She is a certified mediator, conflict resolution specialist, and a non-attorney legal advocate for underrepresented community members navigating administrative, criminal, and civil injustice systems. Next up, Christine Goggins. She was born and raised on the south side of Chicago and is vested in social action and social change. She is currently a violence recovery specialist at the University of Chicago Medicine. For the past 3 years, she has helped patients and their families recover from intentional violence by providing crisis intervention and intensive clinical case management. For the past 15 years, Christine has been an advocate for Chicago residents impacted by violence in different capacities. She is currently obtaining her second master's degree in clinical social work at the University of Chicago Crown Family School of Social Work, Policy, and Practice. Christine devoted her life's work to finding solutions to violence, especially gun violence, when her best friend, Blair Holt, was shot and killed on a CTA bus in 2007. Our next speaker, Ji-Seon Song's teaching and research focuses on criminal law, criminal procedure, and policing. Professor Song's scholarship examines the deployment of policing authority and corresponding effects on racial minority and other marginalized groups. Her research informs interventions that address race and class-based disparities in policing practices. As part of her research on policing in hospitals, Professor Song has created a working group on policing and patient rights. She regularly conducts trainings and provides consultation for medical providers on the intersection of medical care and policing. Professor Song earned a BA in East Asian Languages and Cultures with a minor in music from Columbia College, Columbia University, a JD from Columbia University School of Law, and an LLM from Georgetown University Law Center. Our next panelist, Jarrett Martin Drake, is an educator, ethnographer, and organizer whose commitment to abolition animates the assortment of scholarly and political projects he engages as a PhD candidate in anthropology at Harvard University. Prior to pursuing a doctoral degree, Drake obtained a BA in history and an MS in information science with a concentration in archives, during and after which he worked as an archivist and librarian in multiple institutional and non-institutional contexts, most meaningfully with a People's Archive of Police Violence in Cleveland. Drake was born and raised in Gary, Indiana, where he graduated from the Benjamin Banneker Achievement Center. And then our final panelist, Lena Kerr, is a 4th-year medical student at UCSF, community organizer, and member of DPH Must Divest. Through their organizing work, Lena works to disrupt systems of both community and institutional harm by creating spaces for providers and patients to come together, reflect on, and build alternatives to punitive justice in medicine. They are also an apprentice with the Bay Area Transformative Justice Collective, an organizer of the Do No Harm Coalition, and on the steering committee of the UCSF Repair Project. With their other time, Lena can be found throwing clay on the pottery wheel or building herbal plant allies. And of course, our moderator, Dr. Kelly Butler, who's currently a resident at UCSF and also the vice chair of the Health Justice and Equity Impact Area. Welcome all.
We got a panel today, y'all. We got a panel, okay? So we have some pretty impressive people joining us, and I'm really excited to have this discussion. It's not just me though, it's supposed to be a discussion. So yes, I have my pointed questions, but we have both the Q&A feature and you can send us messages directly through the chat box. If you're not familiar with Zoom now, where have you been for the last 2 years? But also check the bottom bar on the bottom of your screen on Zoom. If you're joining us from Facebook, we welcome you to either directly join our group here, or you can drop questions on Facebook and we will make sure that they're addressed either now or later. So let's get into it, y'all. Okay, so the first one is really for anyone that wants to take it. This is really the only question that is absolutely anyone can address. Yes, we heard your bios, we heard what schools you went to and what degrees you have, but I'm wondering, is there anything that helped guide your journey within the theme of this discussion around law enforcement presence and carceral systems presence in healthcare? Is there anything you want our audience to know about you that informs the work you do that I didn't include in your bio? Anyone can take it.
Don't everybody speak at one time. I'll go. First of all, thank you for having me. It's always a humble and honored. I'm honored to be in these spaces, to have the opportunity to speak on panels like these because the work is so very important. I'm Bakira Shabazz, as you all know, and one of the things that was not included in my bio that people would probably not know is that my work within the child welfare, or I would say child unprotected services system, was directly informed by my granddaughter, my one and only granddaughter, being kidnapped by Tennessee Department of Children's Services for a false allegation of severe child abuse. And so, and me getting extremely involved in that case and doing a thorough investigation of my daughter and the child's father into what happened, and going over the medical literature and all of these things, because I am a professional first. I realized that there was a huge gap in the child welfare system and dealing with the child abuse subspecialty, which needs to be completely abolished. There's faulty science, skewed data that just detrimentally harms families, especially families of color. And so I dived 10 toes into the work. And as a result of my advocacy and my dedication to this work, there has been an order that was put in that I'm now no longer allowed to see my own granddaughter. And it's a legal order, but it's okay. We're still going to fight regardless. And so that in itself is what was the catalyst of me getting involved in the family regulation system reform work, and to really dissect what is really happening here, and to make sure that America and the just internationally knows what's going on within the child welfare, unwelfare system. And so that is my purpose here, to break that down, and hopefully our doctors will agree and take the necessary steps to bring forth some very radical changes in this system.
I think a necessary takeaway here, and we are going to do a recap at the end of our discussion, but is that it can be a personal story, or sometimes it's just witnessing the plight of others that can call you to action. And I think listening and reacting as you see fit is important. So thank you for sharing that story, Bakura. I wonder if anyone else wants to share what helps inform your work that maybe we didn't mention in a bio.
I'll say something. So I agree with you, Bakura. I like how you phrased it, the child injustice system, and I was a juvenile defender for many years. And how I came to this really was one of my clients. He was 15. He was both in the delinquency and the dependency systems, and he was shot by the police, and he ended up in the hospital. And because he didn't have any formal guardian, it ended up being me. And so I ended up at his bedside for about 3 weeks and watched his hospital staff interact with law enforcement in lots of different ways. And it just opened my eyes to something that I just did not contemplate occurred on such a routine level. So yeah, that has really, and his story and the stories of other clients who have had to go through the hospital system and the juvenile injustice system, and then has really informed how I approach this work.
It's a beautiful story to share, not a beautiful circumstance, but a beautiful story to share, that it informed your work, that it's a story you can come back to ground you in the work. A lot of us tend to engage in action because it seems sexy, it seems cool, and we forget to ground ourselves in the why. So I think it's important for us to return to that. Thank you, Ji-Sung. Would anyone else like to share? Yeah, go ahead, Christine.
So I spoke to my position, and I think that's where I've had my most interactions with police in the hospital setting, is literally what I do every day. And I never thought that it would be such a big deal. And it really is. Like, it's crazy to see victims of intentional violence then being re-victimized by so many different systems, not only in the healthcare system, but then also via the police. And it is, like, honestly, truly heartbreaking. Working with the population of young Black males, young Black females, young Black youth, just those who are more so always victims of intentional violence, just to see the mistrust on that level. You know what I'm saying? Like, I can totally understand it. And it is just, it's heartbreaking, but I show up every day and I'm proud because in those spaces I get to advocate for my patients. And, so I think this is a very important conversation, and, us crossing so many different sectors is so important for us to really just dive in. So thank you for having me. Thank you for providing this space. And I'm just looking forward to the great conversation that I know this will be.
Absolutely. And I think it brings all three of these stories and experiences bring a really necessary context to why this session is even necessary. I've been able to work with both Jarrett and Lena in really intimate divestment focused, abolition focused spaces where we were working to remove, divest, or separate carceral systems like prison, policing from institutions of higher learning and healthcare. And so I have a question for both of you, Jarrett and Lena. I'm interested in both of the spaces that you come from, understanding your work with the Harvard Prison Divestment Coalition, Jarrett, and your work with DPH Must Divest, Lena. How do you actually define divestment? What does it mean for a system to divest from some of these carceral systems? Either can start.
I can get going, and I would love to hear from you, Lena, as well. So I've been an organizer with the Harvard Prison Divestment campaign for pretty much the entirety of my time as a grad student in anthropology at Harvard. And the way I think of divestment, I don't know if I would say I would define it, because as a doctoral student, I don't think we're much into definitions because they get a little slippery. But I think of divestment, honestly, in a lot of the terms that you mentioned, Dr. Butler, of a complete severing of institutional and ideological ties. Is both of those, the institutional level and the ideological connections that our institutions have to systems, not only of caging, so whether those be prisons, jails, detention centers, but also to larger processes of criminalization. So I think one thing I heard from the opening vignettes from the other panelists is the different ways in which we've inhabited spaces and been close to processes of criminalization. So it's really focusing on eliminating those ties of caging, of criminalization, and punishment. that our institutions are connected to. So be that policing, police forces. So one of the things that has happened on my campus in the last few years has been the emergence of the Harvard Alliance Against Campus Cops, or HAC, which is one of many different groups across the campus that are fighting to abolish their campus police departments, which we know target Black people, poor people, people in battled mental health crises. And so it's the severing of those ties, but then it's also a shift to investing in practices and processes of safety, of wellness, and of care that our institutions, again, whether they be in schools and hospitals, what have you, purport themselves to be in favor of. But in fact, by having such a close ideological and institutional relationship with these different systems of caging and criminalization and punishment, they actually end up not being able to fulfill those missions. So that's how I think about divestment, and it's been a shared sort of understanding with many others in the Harvard Prison Divestment Campaign, including yourself, Dr. Butler, as you mentioned. So that's how I would respond.
Jared met me as a wee student in grad school, so now you get to flex that I'm a Dr. Butler.
And flex you shall.
You know, and
that.
you know, and it's been awesome to connect with Lena in a space too that is also kind of multidisciplinary and multidimensional in the DPH Must Divest space now in residency. Lena, I wonder if I can bring the same question to you. How do you think about or define divestment?
Yeah, it's hard to follow Jared because that was a very leveled and nuanced answer. And I think I want to expand the levels. I don't think I can provide a definition either, but something I wanted to bring in that's not part of my bio, I think, is also both of my parents were refugees from the Khmer Rouge, or the Cambodian genocide. And so I think having had that relationship and also doing a lot of work with the Asian Prisoner Support Committee in San Quentin, supporting people in understanding histories of trauma, I think talking about imperialism and colonization is deeply impactful for how people experience mental health and the health system, as well as incarceration. And so that's, I think, something that I want to bring into this space as another super structural level of what divestment means. And also to go even more micro, I think, like Jarrett was talking about, it's hard, I think, when people talk about divestment, we're often really focused on the structural and institutional forms of divestment, where, at base level, we don't have a police presence in the hospital system. But when we talk about divestment, we also have to center care and safety, right? So thinking about, like Jared said, how are we building safety teams and support systems for people who are both receiving and providing care, and thinking about the role that healthcare providers often serve as enforcers of punitive justice. So even if police are divested from hospital systems, how are we thinking about mandatory reporting? How are we thinking about 5150s, zero tolerance policies on hospital and clinic campuses, and also how we avoid accountability for fear of liability in the healthcare system. All of those things, I think, are important to actually really disentangling ourselves from punitive justice and policing, and creating systems of safety and care.
Absolutely. And I love that you did this, because it's a perfect segue to a question that I have for you, Bakura. Some people might be in this space being like, why am I here? I'm the good guy. I just show up and do my job. I went to school for many years to deliver care. I took an oath to do no harm. I can't possibly be the one who's perpetuating harm. I'm here to debunk that myth. And I think that Bakura can help me do that and start in talking about how involvement with carceral systems like the family separation system, or CPS, or local police departments, or others often starts with our referral. Yes, we're mandated reporters for a reason. We want to care for people. If we witness abuse, we want to make sure that's taken care of. But that can come with an added side effect of if you will, of causing harm. I wonder, Bakura, if you can speak to your knowledge of how and when physicians may either be the start of the harm or the perpetuator of it, specifically in the context of child welfare.
It's interesting how academia takes this charge over every facet of life. and they control it, and oftentimes can be extremely wrong about their perception. And then this model is followed, like with Kleinsman and Kempe, the child abuse syndrome, how it spawned this whole big medical subspecialty based on one's train of thought, not evidence, but one's train of thought. So when I first came into this work, I said, how do they know that these children are abused? Because there's only one way that we can know for sure that the children is abused, and that is by admittance. Yes, I did abuse this child. And so when you look at the data, do they have a chart that says, did they ask this parent if they abused the child or not? And they don't. And so it's all speculation. Now, when you look at a child that is suspicious for abuse versus a child that has actually been abused, what does that really look like? That data is not there. But then you'll read data that'll say, you can't tell an abused, especially in fracture cases with infants, an abused fracture case and a non-abused fracture case can very well look similar. Then you have data that says that 8 to 12% of fracture cases are actual abuse, when the larger part of the medical data says that most children that are abused with fractures is from physical abuse. And so nobody really takes the time out to really look at what's going on here. They follow a school of thought. That's why I always tell attorneys when they're doing depositions, ask the physician what school of thought do they come from. That way you'll know what guides their opinions. Because if they're coming up underneath these school of thoughts that have this checkbox, they're not going to do any additional testing or finding. They're going to go with the different ages and stages of healing. Majority of fracture cases under these schools of thought will always say different ages and stages of healing. But then when you go to get a second opinion, if it's allowed, the pediatric orthopedist will say, these are not acute, these are all of one pattern, and it was probably birth trauma or metabolic bone disease. And CPS will say, we don't agree with that. We're going to go with our hospital's care team and their assessment. And so it's like, what are we really doing here? Do you want to know if a child is abused or do you not? And if so, why are you so against the family in the first place, especially when you are expecting a family member to know what happened to a child when it could have been birth trauma? They're not going to know unless the hospital admits it. And so oftentimes with lawsuits that happen with these birth injuries, the hospital will take a no position or will settle out of court, but never admit their fault. And so why don't the system believe that hospitals break and kill babies? We know about Black maternal fetal medicine. We know all of these things, but the system just chooses to turn a blind eye on it. And we're going to, as mandated reporters, which I am not, say that we have to follow this thing. And so why is there not a better guideline for mandated reporters? It says that you all are supposed to tell if you think, you don't have to have no proof or no, you just might think this could possibly be. And so you're going to tear somebody's entire world up off of what could possibly, you don't do no additional research, no additional, let me go and investigate, because the mandated reporters doesn't require it. In fact, it tells you don't do that. And so what is this?
Yeah.
That's craziness.
Yeah. And I think you made a very clear point that we too can perpetuate harm, even if it was supposed to be well-intentioned, even if the report came from a place of wanting to do the right thing, we can still be the initiator or perpetuator of harm. And I think that's necessary to understand when it comes to law enforcement presence in hospital settings too. Oftentimes, it's because I called the code that law enforcement comes. It's because I put a patient in restraints that law enforcement comes. It's because I made the report that CPS comes. And so I love that you are bringing light to this issue in that way. I know another way that we often encourage our members to bring light to issues is being in spaces like this one, where we can hear from people of diverse backgrounds, specialties, credentials, etc. But one of the other mechanisms that we love for our members to be really readily aware of and readily use is literature. Publish what you see. Make sure you write about what you've witnessed. Make sure you actually get the word out about the injustice that you experience. I know you, Ji-sun, you had a really beautiful article, the publication in the Harvard Law Review that I read with excitement, not because of the issue that was brought to light, but how eloquently the issue was presented. You've managed to use in your work around research to then just publish what you find and let that be the mechanism for getting the word out. Sure, we can come on panels and talk about it, but now there is a permanent, a fixture, if you will, around the ills that might be perpetuated when it comes to law enforcement in police settings. Ji-sun, I'm interested in talking about why you decide to use that medium of literature, why the Harvard Law Review, for example, and that could have been an op-ed, for example. How has your research and writing effort then helped further the movement as well?
Yeah, thank you for this question, because I've never gotten it before, and it really made me think. And I think it's really provocative, right? Because I used to do this work as a public defender. So I was like really believed in direct services and writing some op-eds. And then I took a real different turn. It was challenging. I mean, this was a real labor of, can't call it love. It was just like a real labor to get what I wanted to say in this piece. And I had I remember talking about this with one of my mentors, and he was like, oh, this is like a Harvard Law Review piece. I'm like, you don't say that to someone who's not yet published something in an academic journal. But I think what he heard and what he heard from me is that I wanted this to have the best platform possible, because what I saw in both the legal literature and in the medical literature was a vast hole, right, of what people didn't know about what was happening with law enforcement and healthcare settings. And so when I talked about my experience with my clients, I came at that interaction from a distinct criminal law lens. And so I was looking at stuff in terms of like Fourth Amendment search and seizure violations, Miranda violations. And I remember talking to the doctors who were letting me into the space, and I was asking them these questions. And I think it wouldn't, if it had not been for my clients who had to suffer like that, I don't know if I could have gotten that kind of close up. And it's really unfortunate that it was that instance and that tragedy that brought me there. But I also feel like it was in some way fortuitous, because otherwise these areas are so siloed. You have law and you have health, right? And I am reading criminal law cases that talk about it, but they seem to say things that when I go talk to doctors about, they're like, that's not how we do business at all. And then I read medical literature and they're like, yeah, these Fourth Amendment rights are so clear. I'm like, actually, they're not so clear. And you have a lot more power than you think you did. And so that is the reason why I ended up spending it was actually years trying to come up with a clear, distinct way to show people in a big platform, and this is when I talked to the Harvard Law students, they were like, we picked this because we thought this is an important issue for everybody to hear. And then that it would shed a light to not just lawyers and policymakers and researchers on the legal side, but that it would actually speak to hospital administrators, people at academic hospitals and teaching hospitals. Like, that's what this elite kind of like brand gives it, right? And I wanted to surface, so my goal was to use this to like really surface what were the legal, regulatory, and law enforcement practices that really underlay healthcare settings, and how that actually these justifications are used to criminalize and further entrench people in the criminal system, but also how this like reflects biases and resurrects this kind of fear of certain patients in healthcare settings once you have like things like shackles and the presence of guards at people's bedside. So I feel like even though it was like a very like literature research-based thing, it has also lent itself to people reaching out from all corners of the country. So like today I got an email from some hospital in the Midwest. The other day I got an email from a hospital in Pacific Northwest, for people who are thinking like, how can I'm actually recognizing our practices in your article, like what can I do to change? And I think that has been like a really beautiful way of kind of like bringing me back to like my original kind of direct services policy roots, from this much more kind of like academic-y kind of side of doing things.
Sure. And everyone in our audience comes from an academic background. If you're a physician, you had to go to school, right? And so I think you brought up a really necessary distinction, that there is power and a real necessity. Just put your head down and deliver good services. Lena spoke to how just creating a good environment in your exam room matters. Making a patient feel safe in front of you matters. But there's also this other level that we have the opportunity to do. And I hope you know that this is the organization to do that through for our attendees. Doctors for America is a pretty ideal platform when it comes to putting that energy behind a real advocacy movement. But you also brought light to the fact that sometimes you need to just step into a platform that is different than your own. Being really mindful of the audience that you're trying to reach and how you're going to reach them matters. And so I appreciate that answer. I really do. In that context, when it comes to thinking about the ways that we can either bring our smaller efforts in a one-on-one patient interaction to a bigger platform that's more healing and safe, or how we then try to replicate the work of others, I want to bring my next question to Christine. I understand that the Chicago Violence Recovery Program was founded in 2019 to support patients and families who are dealing with the ramifications of violence, specifically gunshot wounds, stabbing injuries, and assaults, penetrative trauma. I think this work is absolutely a measure or an effort of abolition, because it's not just about removal or divestment or taking away, but what can we put in its place? And this is a program that is put in its place, right? It's creating a healing structure in the place of what can otherwise be a harmful interaction. Now, I know that this work is meant to be replicated. We just heard from Jisun how you can elevate some of what you just want to bring to light as issues in a literature platform. We heard from Bakura and talking about how you can just use the spaces and use your voice as a tool for elevating an issue. Now, this is your time. If you want to talk to us about how the Violence Recovery Program either came to be, how it might be replicated from some of our members that are on the call here and other systems of care, or just what you want us to know about implementing something in the place of something else that might have been harmful, I'd love to hear from you about it.
Sure. So I love that our program exists. Every day I think about, like, what if we weren't here? And I think what you said was very like spot on about it being a healing structure. Like, our program, we pride ourselves on being trauma informed. So we approach every single patient, every single family from a trauma informed lens, and that makes all the difference. So when you come in, even though, you know, like the doctors, they're doing medical work. We're not expecting them to be rolling out all of the, like, I'm sitting here with you and I have tissue, and our trauma surgeons do that. I can attest to that. They are very hands-on and very therapeutic in their approach as well. But that's literally like our job, you know, so they don't have to worry about that. And I feel like when you have someone that's giving that specific attention to those patients and families, like it goes such a long way, because you have somebody coming in, they've been a victim of a very traumatic injury, and it's pandemonium. Like, it's pandemonium. Like, when you even roll up to the hospital, like, you're gonna see it. People are outside screaming, hollering, crying, breaking down in front of the hospital. They want answers. And so we're there to kind of just like mediate as much as possible. We're providing like support to public safety. And I think that's an important point too. So at University of Chicago Medicine, we have like UCPD on the university side. So we do have like them, and then we have CPD as, you know, like the Chicago police, and then we have public safety at our hospital. So there's levels of like public safety there. And I feel like it's key, because I've been, like, Bakura and I sat on another call, and somebody was on there, and their public safety was like the sheriff's office. And that is like crazy, because you come to a hospital to get help, and the public safety that's there is literally like the police. Like, and you're like, this doesn't even feel like a safe space for me. So the Violence Recovery Program, like, we're there when patients first come in. We're there in the trauma bay with them, like alongside our trauma surgeons and our nurses. We're there when the police immediately show up, because a lot of people don't know this, but intentional violence, like assault, gunshot wound, stab wound, sexual assault, those things have to be reported to the police. So they do show up every single time. It's up to the patient, like, if they want to engage with them. And so our patients don't know. So we have a very important role, because just that presence, like, people think that they have to say, oh, this is what happened to me or whatever, like they have to engage with the police, and we're there to let them know, like, you have rights, like, and then first and foremost, you're a patient of this hospital before anything. So before the police question you, you can say that you don't, if you want to talk to them, fine, but if you don't, how can I assist you? How can I, and I've on more than one occasion stopped and told police, like, this is not the time. So I just feel like it's very important because, and police come in and they're not trauma informed. So they're not treating the patient as a human being. I think, Jerry, you used the word target earlier. They're looking for somebody to arrest. They're looking for somebody who was involved. And sometimes they treat our patients as if they're, like it was their fault. And I'm like, regardless of whatever information that you found thus far, this patient is in need of medical care. And that is first and foremost. So we do a lot of like advocating and just, being a support to our patients. And we have to ask them, and I think the most heartbreaking time for me is when I get into these kind of squabbles with the police about patients viewing the body after someone passes away. You would think that you will do anything to give a patient some kind of peace after a family peace after a patient passes away. When I tell you it's a back and forth struggle every time, and we have to tell the police their own policy. Like, no, these people have a right to view this body, like, and we're going to do it because we're here at the hospital. So you can either let your supervisor know, whoever told you that this can't happen, that there is policy. This is your policy. This is CPD policy. We're showing it to you. We being nice to, let you know, but they give us so much pushback, and like our patients not only receiving medical care, but then also if a patient passes away, like getting that initial peace of mind to just put eyes on a person, you know what I'm saying? And it goes back to that healing. Like, that's the first step. Sometimes people need to see it to make it real. Sure. And that's not, highlighted. So I think all trauma centers, if your city is plagued by gun violence, you should have a program like the Violence Recovery Program. And specifically what our program is called is a hospital-based intervention program. So we're at a level 1 trauma center in a city that is plagued by a lot of gun violence. And that's what we're doing. Like the overall goal is to prevent violence. But before we get there, because that's an uphill battle, we're intervening immediately. And that is key, because that is such a crucial time in a person's life where they're going to make change, and they need a very supportive, just community of people to help them, and I think that that's what it is. So we definitely need to replicate programs like this in all hospitals.
Sure. A quick follow-up from one of our audience members, just asking about how this program is funded.
So we're funded through, a lot of our funds come from outside donors, like private donors. And so we were grant funded for a long time, but now the hospital has also bought in, so they're providing for us to be there. So I am a direct hospital employee, but yes, our program was largely grant funded at its inception.
So I want to come to another hospital-based intervention that, Lena, I know you have been most aware of in the DPH must divest space. This initiative exists because the San Francisco General Hospital, which is a level 1 trauma center, certainly has its fair share of trauma that comes through its ED and trauma bay. Our hospital police presence is the San Francisco Sheriff Department. And it's not the time for me to go into all of that means in my own experience in delivering care there, but I would want to just focus on solutions right now. Let's do that. And so I want to hear from you, Lena, about the BERT team. The BERT team is an acronym for Behavioral Emergency Response Team, I believe. And so I'd love for you to talk about this as a hospital-based intervention that DPH Must Divest has openly supported.
Yeah, absolutely. I think with a lot of community support, right? Like Christine was saying, a lot of this stuff isn't initially funded, isn't initially supported by hospital administration, that are not necessarily, whether through financial or political or whatever kind of constraints, are not necessarily prioritizing these things until the model is already there. But yeah, San Francisco, like Dr. Butler said, is in kind of the minority of hospitals that have an active police presence and collaboration. And one of the reasons I think that police are often brought onto campuses is because providers feel under-resourced to address escalation or violence and then need someone to call, which historically the only option has been the police. And so the BERT team was started like very small scale in 2018 to provide behavioral support for non-psychiatry units and to support patient and provider safety while reducing police presence at the general. And so with a lot of push from community members, DPH must divest, a lot of providers in really high use spaces, you know, like psychiatry emergency services, the ED, or emergency department. Our current plan for BERT is to reduce, sorry, that's my cat's tail, to reduce the amount of sheriffs and instead invest in psychiatry nurses and psychiatry technicians that are trained in de-escalation and emergency response, which actually is, you know, is a healing model. And it's been slow going, you know, with budgets, and like we still have some room to grow in meeting that goal that DPH has agreed to of decreasing 11.4 full-time equivalents of sheriffs and investing in 31.9 full-time equivalents for psych nurses and technicians, but it's been up and running, and it actually has been really successful at responding to crisis without police involvement, you know, where a lot of times when people are called, it's like someone is screaming, I don't know how to get them to stop. And the solution is not to call police, but instead to just listen to what they are upset about. And to be trained in deep listening, which I think is something that, you know, I'm really glad that we have people who are deeply trained in it and are really specialized in it, like the BERT team. And also, like, ideally, we would like everybody to be able to have some of these skills, if not all of these skills, so that we can all be addressing harm, we can all be de-escalating as part of healthcare, as part of a healing model. But BERT has been a really great way that people are investing in people to get trained and to build out that training and support for hospital systems, and hopefully we'll expand into clinic systems too.
So I hope that Christine and Lena offered you as participants today examples of very tangible, doable hospital-based interventions. Sometimes it's a tall order to imagine abolition, to imagine systems of carcerality just not existing. It's hard for us to say, you know, Bakura mentioned earlier, what if there's just a world without CPS? Just abolish it all, knock it all out. In the Harvard Prison Divestment campaign, there's a very real call of just complete separation. We just shouldn't have anything to do with carceral systems. One of the questions from our audience that I want to bring to you first, Jared, and then I'll open it for anyone else to address. What then do we do when these things don't exist? It's a very common question that we get as abolitionists. And I wonder how you respond to the questions about abolition that challenge the removal of carceral systems. Like, who do I call when a patient gets combative? Where will the rapists and serial killers go without prisons? What do we then do when these systems of carcerality don't exist? Who do I call if I do see a child who is absolutely being abused if CPS doesn't exist, right? So I wanna start with you here, Jared, because I know it's a very common question to get as an abolitionist, and I'm happy to open the floor for anyone else that wants to respond.
Yeah, you're correct. Absolutely, that this question gets asked a lot. I'll answer it in a few different parts, and I'll try to be as quick as possible. The first way I respond is actually by echoing something that I've heard Barbara Smith, who's one of the authors of the Combahee River Collective, a longtime organizer, scholar, writer. And one time I heard her say on a panel that people ask post-revolutionary questions when we're in pre-revolutionary times. So oftentimes the sort of impetus behind the question, while coming from a sort of genuine place of like, what do we do when danger arises? Often the answers that would actually satisfy those, none of us actually knows at the moment. What we do know at the moment, though, as every panelist here has suggested in different ways, is that the police and the prison system don't adequately address those items either, right? One of the biggest pieces of police and prison propaganda out there is that the police exist to keep us away from dangerous people. And I said this during a lecture that I gave to a class a few weeks ago. I feel comfortable saying it here. Part of the way our society decides about how to deal with serial killers, with rapists, has a large part to do with, number one, who's the target of their harm, and what's the identity of the person doing it, right? And depending on the pedigree, the sort of institutional pedigree and the racial pedigree, the gender pedigree of that person, they may just as well end up on the Supreme Court or in the White House, right? That's what our society does with people who commit certain types of harm, right? And depends on who they target. And we also need to scale up our sort of idea of what it means to cause harm, right? And what it means to do violence. Because so often, again, when the police and prison apologists and public relations offices have dictated violence, it's in this very sort of almost like a street level sort of interpersonal conflict issue. And, you know, so something such as I live in Cambridge, Massachusetts, and I'm looking out my window and I see certain structures put up to displace homeless people, houseless people from sleeping safely, right? We don't think about that as violence. That's absolutely violence. So I think in terms of like, what do we do in the interim, right? One of the sort of plugs I would like to make, number one, is just for to big up what Lena and Christine were talking about. Those are very practical solutions that have worked. They've been done for decades and generations. And the other plug I would make is to look at different other types of professional organizations that have come up with strategies of how to, especially institutions similar to hospitals that deal with interact with the public a lot. So in my bio, I mentioned that I used to be a librarian. I would say outside of the hospital, the public library is one of the main sources of public contact. There are lots of, it's one of the few places these days, actually more so than a hospital, where you go in and you don't have to even show ID or prove that you like deserve to be there. So there are a lot of things that are happening in our communities and our neighborhoods that wind up at the library. There's a group that got created. I'm not a part of it. I've been following it from afar, called the Abolitionist Library Association. And they've been putting together workflows to identify what are some specific de-escalation tactics that we can use as library workers. And usually what it involves is again, something that Christine and Lena both mentioned, getting in contact with organizers, with groups of people in the neighborhood who are already working towards these issues. So I think a lot of things that we as abolitionists are looking for is actually already being in practice. It's just usually under-resourced or demeaned or sort of sidelined in sort of this sort of veneration of what the police in a prison are there to do. Go look, I would challenge anyone, go look up how many untested rape kits there are, right? If you think the police are there to stop rapes, go look at those numbers in whatever city or jurisdiction it is that you live. Police and prisons do not exist to protect us from the harm that they allege to protect us from.
Sure. I see your hand raised too, Christine, if you wanted to come to this question next.
Yes, I just want to, Jared just made me think, because when he said things that already are in existence, I just want to highlight street outreach. When I tell you that is the most like underrated, they don't get as many kudos as they should. When I tell you street outreach is really making a difference, it is like, it's amazing because they have been out here in the streets. They know our community like the back of their hands. They are still very active. The young people that's out here that are involved in gang life or are not involved in gang life know a lot of street outreach workers, and they are doing the work on the ground. So I always like want to just highlight them, because I think in a world of academia, we don't look at street outreach and give them the respect that they deserve, because they're it's like they are doing practice-based evidence, you know, and we're so much for science-based evidence, and it's awesome, you know, but we need both of them in tandem. So everybody out here that's doing the research and everything like that, if we just bring street outreach more into these spaces and these conversations, the solutions are already there. They literally have them and are enacting them every single day.
Sure. I love the idea of taking inventory, because It's something I had to learn the hard way, that we don't have all the information despite all the degrees we have as physicians. And this panel was created really intentionally. Notice there's not a single physician on this panel except me as the moderator. And that was really intentional, because oftentimes we're just talking to each other. It's doctors talking about the work that they're doing to other doctors and not coming from an interdisciplinary space. You, Lena, and you, Christine, both made the point that a lot of these hospital-based interventions are actually not carried out by physicians. We don't have the time to. And I'm not saying that you don't necessarily have the time to help implement these interventions. If anything, you have the most power, attendees, to help start the conversation. What we can't do, though, is rely on just physicians to be doing all the work. And I think that's really important. Lena, did you want to come into this discussion around this question too?
Yeah, I wanted to think about, like something that we talked about is that the hospital system, because of its police presence, is not serving folks already. Like, I think the statistic is something like 70% of people who experience sexual violence don't go anywhere. And so our system that we have already is not being met. The way that people are most often getting care is through their friends, through their family members, through people that they know and trust and have relationship with. And so I think that if we're going to build alternatives and build solutions, that there are people who are already doing it. And honestly, it's the majority of people who are already doing it. And we're in the minority, and we're trying to catch up. I also wanted to say, I think in response to the question of, what about these really high level conditions of harm? I think, like Jarrett said, that's not real. That's, if you're going to try to learn how to swim, you're not going to go in the deep end of the pool first. And so I think in thinking about, in my transformative justice experience and background, violence as a pattern of escalation. And so people don't go from day one into these really intense levels of violence. But we also don't have the skills or capacity, and often don't have as much practice even addressing smaller issues of violence, right? Are we addressing small stuff like roommates cleaning dishes is a way that we can start to practice accountability and practice non-punitive ideologies, like Jared talked about to begin with too. So I think, when we're thinking about how are we actually going to move towards abolition, all of the small day-to-day things matter too. How are we actually having conversations with other staff about, are we going to maybe we should take a pause before we report this person. Maybe we should take a pause before we call a code or call the police. Maybe we should think about other alternatives before shackling, or maybe I think there's a lot of ways to get started that are less intense than just jumping right into the sexual assault, rape, murder. Yeah.
Absolutely. And I think people misunderstand abolition as an all or nothing, and that there can't be steps taken towards that ultimate utopia, that ultimate larger goal. I think you can take steps that are not just reform, just making things more comfortable in the meantime. You can take steps that are abolitionist, and some of these interventions are examples. Jusan, I see your hand up if you wanted to join this discussion on this question.
Yeah, so I wanted to just talk again about mandatory reporting, right? So there's a bill circulating right now in California that will take away mandatory reporting for sexual violence from doctors, which I think is and this is, so it goes back to what Jarrett was saying. It's there's this kind of catastrophizing that always happens when people think about abolition, or they think about criminal law, they go immediately to the murderer and rapist and think that we need these things in order to catch the murderer and the rapist. Well, for example, if we take mandatory reporting for firearm offenses, those end up with the person who got shot being arrested for being a felon in possession or something like that, right? And so that's what these laws actually end up doing for these low level kind of things that populate a lot of our prisons and our jails. And so even just thinking about Lena, you were kind of saying think about it. There's a lot of discretion before we even get to the point of abolishing mandatory reporting, right? But even these steps of thinking how me as a medical provider, what's the arsenal that I don't mean to go into firearm analogies or metaphors I did, but what kind of tools do I have to really push back against this law enforcement? What do I know about shackling right? And how it harms my patient, that I can push back against saying, you can't do that right now for someone who's like going in labor or who's paralyzed or whatever. And I think that also that applies in so many different ways. And I think that's like what's been so exciting to me to work with doctors is like, you all have so much power if you only flexed it, you know? And anyway, that's my 2 cents that I wanted to say right now.
Listen, get on your soapbox. Today's the day. This is the time to call doctors to action. That's exactly what we do in this organization every day, and this panel is no different. Bakura, I want to come to you for our last comment on this question.
Yeah, thank you so much. I was also piggybacking off of the mandatory reporters. The issue is that it doesn't allow for flexibility. If you suspect or if you think an inkling of it, you must report or you could possibly lose your job and your license. That in itself is violence. And as to Jared was saying, we really must think about balance. So you have legal versus illegal, and there is things that are legal that are violent. Like the police can kill you, and that's deemed in society as it's not violent. But you'll have black on black crime or white on white crime or whatever, and that's violence. And how is society separating the two? Violence is violence, you know, regardless of who commits it, and what allows a profession to commit violence against another one. If what we're trying to do is reduce violence, then we cannot promote it at all. And one other thing is just common sense. I just, as a critical thinker and a non-attorney legal advocate within the Criminal and Justice Reform Network, we go in, we actually handle cases. We cannot give legal advice, but we are there protecting people's due process rights and ensuring that lawyers are doing what they're supposed to be doing, or we will file a complaint against you and or the judge, whichever. And so community-based organizations are extremely vital, as Christine was saying, and very overlooked and highly underfunded. But we are doing that footwork that academia and the system and professions may not have the time. Lawyers, a lot of the time, don't have the time to really dive into the meat of due process. It's like, listen, I'm just trying to get my client off, but it's all of these other violations, constitutional violations that your client is going through that you're not addressing, which is is violence. And these micro and macro aggressions are also violence. And so when we talk about abolition in this lens, it is, to me, removing violence. That is what abolition is taking away violence,
Sure.
Period.
Absolutely. Absolutely. I'm gonna end there, period. So I want to know your thoughts on this discussion. I could have had it for another hour, easy, but we kind of came to our time today. And so as attendees, I'm interested in your thoughts on this discussion. You see a survey link in the chat box here, and you'll be emailed it as well. Just recapping some of what we talked about, though. I want to highlight that sometimes it's a personal story, or sometimes it's just witnessing the plight of others that can call you to action, listen, and react as you see fit. Lena and Jared both offered us how to think about divestment as either a complete severing of institutional and ideological ties and connections between our institutions of higher learning or healthcare delivery that they have with caging, larger processes of criminalization and punishment. We also need to be aware of the role that providers serve as perpetuators or initiators of harm. So it's important to take the time to ask all parties involved where or how harm might have been caused before making the report, before taking the action. And then we need to be aware of our power, both as mandated reporters and just as physicians, period. Everyone on this panel has stated how powerful we can be, or you could be. The platform matters when it comes to publishing on the ills you witness as a provider and the issues you like to be brought to. Your lens and your desired audience also matters when choosing that platform. In the spirit of abolition, though, we need to really encourage interdisciplinary reporting, storytelling, if we're going to do this right. And beyond that, there's a number of different resources that we've been offered today that we will definitely send you when it comes to articles to review, zines to read, ballot measures to pay attention to, presentations that were given, lecture topics that were offered. There's a lot that's happening in this space, and I want to encourage you to be involved with it. Beyond this talk, Doctors for America does some really awesome stuff. So I want to talk about that stuff too. But to our panelists, my deepest, deepest thanks for giving your time and your talents on this panel today. You brought together a conversation that we don't often have as physicians, but I think we need to be. And I hope that people know that this is a space where you can return to for these conversations. Bijou, if you want to close us out with just some quick reminders of DFA things, what's coming up, and how we can be engaged further with our health, justice, and equity impact area.
Absolutely. Thank you all again for your time. Just echoing Kelly's sentiments. This was really amazing. And I really appreciate all the work that everyone here is doing. It's really inspiring. So this whole session, if you weren't able to catch it or you had to log off early, it will be available on DFA's YouTube channel, so please circulate it. And then also please take 2 minutes to complete our survey so that we can learn more from you about what went well and what sessions you'd like to see in the future. And you can find the link in the chat as well. And then thank you all for being here and for everything that you do on behalf of our patients. We hope that you will become an official DFA member today, and that you will take a look at all the benefits of membership on DFA's website, like we talked about earlier. Please follow us also on all of our social media links, including Twitter, LinkedIn, and Facebook. And the Health Justice and Equity Group, we have a few exciting events coming up. On May 24th, we will be doing a panel about Dobbs versus Jackson and what's next and what we can do to advocate for our patients in that space, as well as we have our action event in 2 Sundays from now, May 22nd, I believe, where we will also be working on writing op-eds and LTEs. So thank you all for all the amazing work you do and all your advocacy.